Thank you, Prof. Shanggar, and thank you, Prof. Siva. So I think it was a very interesting talk. And although we are in primary care medicine, I think we also see these kind of cases when they actually present early. So just the other day on Monday, I saw a patient with enlarged mediastinum. So for us, knowing this, latest modalities for tumor in the thoracic cavity is also important. So now I'm going to introduce you, Professor Dr. Norita Hussein, who's a senior consultant at the Department of Primary Care Medicine. And she's been with us for more than 20 years. So she obtained her master in family medicine, and after that, she pursued her PhD at the University of Nottingham, UK. And her thesis is on preconception assessment of genetic risk in primary care. She continued her work in genetic and screening studies, and in 2019, she did her fellowship program at the National Human Genome Research Institute in the US. So Prof. Norita has authored many international papers, including a Cochrane systematic review. So without further ado, let's hear from Prof. Norita on why family matters.
Thank you. Thank you, Dr. Camilla, for your kind introduction. Right. So, Salam Idul Fitri to all of you, my colleagues. I hope you had a good time during the Hari Raya. Okay, so today, I'm going to present something which is close to us, family. Okay, so why family matters. So before I proceed with my presentation, can you just scan this QR code and give us three possible. What do you think when I say family? What does family mean to you? I will give you 1 or 2 minutes for these things. Okay. So it's very interesting to see that love is actually the main thing that is being depicted here, and same gene, extended families, genetic conditions, relations. Okay, so it is still evolving. All right, so support. That's great. So, all right, thank you so much for your participation. That's really awesome. All right, so I'll just stop sharing this and just go back to my presentation. So, when it comes to family, all right, so sometimes we talk about similar behavior. I can see same gene within the results just now. Similar belief, common culture, common habits, common environment, common food. Okay, continuity of generation. But there is something that is probably not commonly or not is not usually being discussed, which is health. So my topic for today is family and health, actually. Okay, so this is just a caption of the day. All right, so we know that until health or illnesses manifest themselves, okay, so it will go unnoticed. So until it gets being asked or tested, it will not be addressed. And this is unacceptable. Okay. So why is family and health is important? All right, so at least 1 in 10 of the patients seen in primary care has a disorder with a genetic component. We talk about same gene, okay? So at least 1 in 10 of patients that we see has a genetic component. So family is actually very important. We know that patients that come to the health clinics or primary care comes from a lot. Most I can see at least 50% or so are having non-communicable disease, for example, diabetes or chronic asthma, hypertension, cardiovascular disease. All right. So, and we know that in the statistics of Malaysian statistics in 2023, ischemic heart disease, cardiovascular disease becomes the top most, at least the top 10 most cause of death. And including malignancy, hypertension, chronic lower respiratory disease. And we know that thalassemia, an autosomal genetic condition, at least about 5% of Malaysian population are carriers. And it is actually very high, even higher in the Borneo, in the Sabah, which is about 20 to 35%. So that is why, in terms of family screening, is very important. Okay, so what actually triggered me to present this topic is, sometimes we take classes, we take medical students for class. Okay, one morning during clinical teaching, in the history taking, we have all the checklists that need to be completed during the history taking. Okay, so family history obviously is one of them. So when they present, it always, father has got hypertension, mother has got diabetes, and it just stops right there. Okay, there's no additional information towards that. All right, so I will just pause this for a while and go back to why do we need to do a family history, right? So it's actually a gateway to recognize inherited disorders in a patient, predicting individual risk for early diagnosis, decisions on genetic testing, and reproductive choices. So family also captures the complex interaction between genetics, environmental, sociocultural, and behavioral factors. And it's a strong non-modifiable risk factor for cardiovascular disease, diabetes, and cancers, right? So it can be the only primary risk factors. And the reason why we need to have an objective, why are we collecting family histories? Every single component in the history taking has got an objective. Okay, why do we need to take present illnesses? Why do we need to take past illnesses? Okay, medication history and so forth. So when we talk about family history, there is an objective to it. Okay. All right, so it can identify if there is a positive family history. We can identify inheritance patterns. All right, risk assessment. We can do a risk assessment and stratification. We can initiate patient education, for example, diabetes or lifestyle. We can, all right, of course, we build rapport with patients and their families. We identify shared environment and behavior that put patients at high risk. Okay. We can have an informed decision on screening and preventive measures, and then we can do appropriate management and referral. Okay, so in existing literature, although we know that family history has been part of the clinical consultation, family history taking at least in primary care is still not routinely practiced. Okay? Many who were at high risk with strong family history were missed by the doctors. And the quality of family history documentation is also lacking. And despite the recognized importance of family history, challenges remain on how to implement effectively as part of our busy primary care practice. Right. So because of this hypothesis and because of this theory, we decided to carry out 2 qualitative studies and an audit. The first study was exploring primary care doctors' views and experiences of using and collecting family history. We had 20 participants from the primary care health clinics as well as the private GP. The second study, we actually explored the carriers of thalassemia about whether they know the importance of being a carrier. And then we also carried out an audit on 20 MOs in a primary care clinic. Right, so I'm just giving you a snapshot of the results of these studies. So in the first study, the doctors unanimously agreed that family history is important for patients to know, and primary care doctors have a role to play. Okay? And they recognize that family history is important to track family members with suspected genetic conditions. Right? They recognize that family history helps to assess patients at risk of genetic conditions for early screening or early intervention to be carried out. So one of the quotes says that I think it's important to every patient to know what is their family history, whether any values in genetic disorder, anything like that. Especially, I think it is mandatory for pregnant mothers. And the second participant said, it is very important to ask about that. That's why I said earlier, if the patient comes to see us for your RTI, has a background of family history of diabetes, maybe from there we can advise on lifestyle. Right? So nevertheless, family history was not routinely practiced or consistently collected. So it seems that the prevalence of medical conditions was an important factor in influencing whether primary care doctors would ask for family history or not. So the most commonly asked were diabetes, history of diabetes, and history of cardiovascular disease. And took family history only from patients who are on regular follow-ups or formally registered with the clinic or the doctor. And the doctors felt if family history was only asked if the doctors felt that the presenting complaints were relevant or related to specific genetic conditions. Okay? So, for example, one of the participants said, if the patient comes to the clinic only for acute problem, to be frank, I don't take family history. I ask more if they are regular patients or registered to my clinic as a family unit. Right? So I didn't really ask every patient that you have the family history of cancer unless they have some symptoms. Okay. So, and of course, the content and the methods of asking of and documenting family history varied. Right. So, family history was asked as a general question and usually up to the first degree relatives. And free text or narrative text was preferred. Well, the reason was because of the EMR was not user friendly and did not support the drawing of a pedigree diagram. And one or two participants said that documenting a pedigree diagram was not considered important because genetic conditions were perceived as uncommon and drawing a pedigree could be time consuming. Okay, so that was the first study. And the second study, this is a study, we interviewed the thalassemia carriers in Sabah. Right? So they're not patients, they are the families of patients with thalassemia. So they knew that thalassemia is an inherited blood disorder and family members could be affected. And so one of the participants said that I was the one who asked to be screened. I had gone to screen myself. And because I had a younger sibling who had thalassemia. So this patient understood why she had to go for screening. And it seems that religion was found to play an important role in finding strength for family members to go for screening. This is partly because of the thalassemia is a genetic autosomal recessive conditions. So to understand the consequences of having being a carrier or having thalassemia major, so they had to find some support to go for the screening. Right, so, but on the other hand, we do have carriers who don't know the meaning of being a carrier. So participants were not concerned about the diagnosis and the importance of family history and screening despite an established treatment. So this participant said, I didn't tell my siblings to get screened because I thought it was just me who is a carrier. I thought I was the only one. So, so that was about the qualitative studies, and we carried out an audit on medical officers to ask about how do they practice a family history. So these are 20 MOs actually participated in this audit. If you look at this, the first component, okay, taking family history is useful. Majority actually agreed, but there are one or two did not agree actually family history is useful in all consultations. Right, and mainly agreed that taking family history takes a long time. And mostly actually take up to first degree relatives, and a small proportion took up to second degree relatives. And actually, none of them actually took up to third degree relatives. And a small proportion only update the family history of their patients. Right? So it seems that it's just a one-off family history taking. It's not consistent. It's not updating. Okay. And if you look at these patients are able to tell their family history, I think in the context of remembering what happens in their family, I think there is some gaps here, whether the family remembers or family know about their own family history. Okay? So only a small proportion of the doctors actually agree that patients are able to tell their family history. Mostly document family history narratively, and a big proportion also did a pedigree diagram. Okay, so when we asked about which group of patients do they usually take family history, uh, actually all of them actually took family history from newly registered patients, and just about half only are established patients or follow-up patients. Okay, and patients who come for an acute complaint, right? So only perhaps more than 50% actually took family history, even though come for acute complaint, whether or not they is relevant to the acute complaint or not, right? Okay, so I'll just leave it there for a while. Right, so again, I go back to the exercise that triggered me to present this the importance of family history, right? So just to have a brief revisiting family history, so I think one of the things that if you look at the previous results of audit, most of them actually took only up to first or second degree. I think information from family history has to be a 3-generation pedigree. And then not just talking about the illness, but also when did the illness occur, the age of the diagnosis. And it's good to know if there is death in the family because of illness. It's good to know that the age when this happened, and who else in the family has similar illness, right? And family origin or ethnic background is also an important component. All right, and marriage among family members or relatives, and also previous pregnancy history as is an important component in the family history as well. So it's just a red flags. Why do we need to get all this information? Because earlier age at onset of illness than expected, the risk is higher when there is developmental delays or mental retardation. All right, so you think about genetic conditions in the family. If you find that there's only male seems to be affected, it's mostly X-linked, and if there is recurrent pregnancy loss, think about is there any underlying genetic component. Okay. So this is a table from the WHO, the US prevalence of disease. Why is it important to have not just first degree relatives, second degree, third degree relatives? So because the risk of having the illness is much higher than just having a first degree relatives. All right. So again, family history, we don't just stop on one-off information when taking family history. You should update every 5 to 10 years, especially if this is a recommendation especially for patients between 30 to 50 years old. And family history should be collected routinely and opportunistically. It's not just when you think that it is perhaps related to the symptoms of presentation. Right. So we talk about there is some issue whether is family history information effective in motivating every individual, because we know that if you know the family history of diabetes, for example, you would want to advise on lifestyle changes and so on. So we know that at the moment, the health education programs, which aims at the full population, have limited effect. And I think in the era of genetic profiling, the role of genetic profiling also has limited evidence in preventing illnesses in at-risk individuals. Right. So, but there is increasing evidence with family history in terms of the awareness of risk and lifestyle changes, although it's still limited. Okay, but there is increasing evidence, and there is increasing evidence in the behavior change in the eating habits, and people who at-risk individuals goes for yearly annual checkups, especially to check their blood pressure. So there is some evidence to say that knowing family history information is effective in motivating at-risk. Well, sometimes some family member doesn't seem to wanting to know what's happened with the family members. Okay, um, it's a fate, for example. Okay, so are there any potential harm in knowing one's family history? Well, traditionally, people have been discussing about confidentiality. Um, you know, it's an illness is a confidential element. Okay, we'll talk about stigmatization, and of course, sometimes it affects emotional and psychological um, um, elements there. So, but I think with with increasing awareness of these genetic conditions, of the importance of family, this has become not the main issue being discussed. Okay, so knowing family history has got some potential good benefits in it. Okay, so all right, so I talked about family history. Why is it important to do family history? All right, so the other thing is, this brings to my last few slides, the role of family in health promotion. Right? So WHO has actually documented that family is an important contributor to the behavioral, social, and cultural conditions that support health. And they realize that the value of family is often overlooked in health promotion initiatives. So in the they are recognizing families in their in the 21st century health population, in increasing population health. So for this matter, so the proactive efforts in NCT interventions and because intervention targeted at both family and individuals gives more synergistic effect the individual alone. So in this WHO WHO framework about the action plan in the strategy of 2021. So we can see that tobacco use, unhealthy diets, physical inactivity, harmful of alcohol in this cardiovascular, diabetes, cancer. This can be integrated with family intervention. Okay. So and health is wealth. So we often talk about legacy when it comes to family. And I'm not sure whether you agree with me. Sometimes during any gathering or any family occasions, we talk about when we talk about family, it's always about property, living property of 2 millions, or even recipe turun temurun. Okay, lemang turun temurun, for example. Okay, all right. So let's talk about health when it comes to family. I think one of the things that we need to do is to empower the family members to tell family stories, perhaps um, um, to know more about their family members. What happens in their family? All right, what is the cause of death? Well, it depends on not just it depends on the occasion when to have this conversation. But I think this is just to empower so that we share and we can do something about it. We can do some prevention if we can. All right. So we can do some proactive actions. That's the main aim. And or we could do a National Family Health History Day to promote the conversation among the people about family histories. The US has already implement this in their annual National Day for National Family Health History. This is just the last one is just the link for the public to know about more about family history. So just I just want to have some take-home message before I end this webinar. All right, so just to revisit family history is actually a very powerful tool, especially in our low resource settings. Okay, it does not only reflects the consequences of genetic factors, but captures the interaction between genetic, environment, social, cultural, and behavioral factors. And we need to improve our practice of family history taking from good to have, a must have. Ensure comprehensive documentation with the objective to help in action plans. And we must recognize that family history is a dynamic process, and regular updates to family history can help keep track of real-time risk. And for the public, or for us, we need to empower the public to share family health history, family health stories, okay, engage both family members and at-risk individuals to improve health and well-being, and recognize the importance of family involvement in health promotions and interventions. So whether you like it or not, family does matter. This is my reference. Okay, so I thank you.
Okay, thank you, Prof. Narita. Thank you, Prof. Narita. I think you've highlighted the importance of family history in primary care. So actually, there are a few questions in the chat box. I think so you're okay to continue, yeah?
Okay.
Right. So the first question is from Professor Tengku Sara. So I think this is a very practical question. You know, when we take history, how should we ask about a family history? Is it just good enough asking any illness in the family? Do you get the question? So, you know, when we take
How do you
history,
think? Sorry, thank you, Prof. Sarah. How do you think we should ask about family history? Obviously, and any illness in the family is not good enough. So, yes, there are. It depends. Okay, there are different ways of asking whether you want to, whether is it just ask a general question first. Okay, is there a family history of? Is there any illnesses that is happening in the family? Or there's no right or wrong here. You could also ask about if you feel that those with a genetic component to it, and we could do something about it. For example, if there is no answer from the family, from the patients, we could go to the focus question. For example, is there a family history of diabetes or hypertension? So there's no actual ways of asking. So I hope that answers you, Prof. Sarah.
Okay, so from Prof. Chan, when potential patients in the family are identified through this process, what is the uptake of this coming forward to take opportunity in further care, for further care?
Thank you, Prof. Chan. So, okay. So when potential patients in the family are identified through the process, what is the uptake of this coming forward to take? Okay. All right. So, I can give you an example of cascade screening for thalassemia. So, from what I have read, okay, so the uptake of cascade screening is actually not very good. Okay, so for thalassemia at least. And the reason being is there is still some element of fear of the results, and of course fear of stigmatization, especially when it comes to marriage or relationships. So, but we are hoping that in future um, em- we in the planning of empowering public or community to actually help in terms of this intervention that helps patient to come forward and do the screening.
Mm. Um,
Prof.
I've got this
Saja.
question, Prof. Saja. Are there existing standard questions or algorithm in asking family history?
Okay,
The
so
first one,
um um sorry, yeah, okay,
I
so
think
Prof.
it's quite
Saja,
similar.
thank you, Prof. Saja. Yes, um I can say that in our EMR, there is no algorithm or standardized questions as yet. So it is just a narrative or free text documentation. Okay. So, but um, there are studies that there are other centers that have an algorithm, or um, which is that is the thing that we are actually um, promoting, and at the moment it's just like one disease, it's just one condition. For example, cancer, it's not, or breast cancer, it's not the whole genetic condition, it's not other inherited disorders. So we are going through that, we are looking at that, and we hope that at least to help our MO to have to ease the taking family history in their day-to-day consultation. Thank you.
So I think that's this one last question because I think the other question is related to the one that you've just answered, the MR taking history, family history. Um, this question is about what would you recommend to sensitively explore the issues of consanguinity?
Mm, sorry, can I just have again? It's
So
not in
you know,
here. Always.
it's actually in the webinar chat. So
Oh, webinar chat. Oh, okay, okay. Right.
so how would you recommend to sensitively explore the issues of consanguinity?
Hmm. That's an interesting question. Okay.
Yes, it
So I
is.
think, yeah, um, we we the most important thing when it comes to relationships is to explore first their understanding of of the um, the consequences of having marriage between family members, and sometimes at the same time when we discuss about this matter, we also have got to be aware of the culture of this community, what lies behind it. I think from that onwards, then we can actually tackle or um, tackle the conversation on how to go into the consanguinity issues. That's my that's how I would perhaps recommend.
Thank you. So I think thank you so much, Professor Norita. So I think that's the end of our UMHealth. So I think it's still not too late for me to say Selamat Hari Raya to everyone, as well as I hope everybody enjoyed the talk. And have a good day and a productive day. Thank you.
Thank you so much, everyone. Assalamualaikum.